The Army of Women is a revolutionary, unique new partnership between the Dr. Susan Love Foundation and the Avon Foundation to recruit women who are willing to participate in research so we can find the cause of breast cancer and how to prevent it.
The Love Avon Army of Women is really going to revolutionize the way biologists can do breast cancer research.
We really need to be able to look at women both with and without breast cancer because we need to see what's happening in the breast before the development of a malignancy and after, and the changes that are related to that.
Tonight we take a closer look at an ambitious new effort to fight breast cancer. A movement called Army of Women is trying to recruit 1 million American women, whether they're healthy, at high risk for breast cancer, or survivors of the disease, to be part of a sweeping research project. 2.5 million women in this country are living with breast cancer.
She and the Avon Foundation have launched a website in hopes of gathering the largest pool of women ever for breast cancer studies. Women simply go online and enter their basic information, name, birth date, and zip code. Their goal is to have a database of 1 million women.
We need all types of women. We need all ethnicities, we need all ages, because if we're going to figure this out, we need to represent everybody who might get breast cancer.
Dr. Susan Love says breast cancer research has been hampered by a reliance on lab animals, but no longer.
If we're going to figure it out, we have to figure it out in women.
The problem with a lot of breast cancer studies, to put it bluntly, most of the women in these studies already have the disease. Now a leader in this field has stepped up. She's looking for women to help change that.
www.armyofwomen.org and sign up. And what you're signing up for is not to be in a project, but that you're willing to participate in research. And then we will bring projects to you that different researchers are doing around the country, and you can see if you fit. And if you fit, we'll match you with a researcher. We'll help collect whatever they need, blood, tissue, saliva, and then we're on our way.
Army of Women. It is the brainchild of Dr. Susan Love, who joins us now. She's been a familiar face in the fight against cancer. Very popular here out on the plaza. And, you know, we are 40 years since declaring war on cancer, and you say, you know what, we have not done enough. What should be done now? Why haven't we gotten to where we need to be?
Well, you know, we've been focusing on finding the cure, which is great, and we've done a lot of advances in treatment, but we really don't know what causes breast cancer or how to prevent it. And I think the time has come to stop it altogether. And in order to do that, we need healthy women to stand up to the plate along with their sisters with breast cancer and the high-risk women and really participate in research. And the Army of Women is going to help them do that. Join the Army, because we need you. We need everybody in this Army if we're going to eradicate breast cancer.
By signing up for this very special Army, I might be one of the 1 million women who will help defeat breast cancer in our lifetimes. So I urge all of you and all of the women in your lives, that means get 4 and 5 and 10 and 12 of your friends to sign up too. Sign up with me. We'll do it together.
We've got 278,000 women.
Okay.
Sign up right here.
My daddy said, wait a little birdie till your wings get stronger. If only he knew I'd have to wait a little longer.
We're taking that commitment to the next level, that we are being more innovative, more modern. It is a revolution today of technology and a revolution of vision.
I'm flying so free, so why won't he come, just come and find me?
We are all fighting for a cure, but what would be great is to actually prevent it in the first place. So everybody should go to armyofwomen.org and join this wonderful group of women.
Wings get stronger, a phrase I knew then that I forever ponder. Oh yeah.
The scientists need it, the women are ready to do it, and we just need to bring them together. We're the eHarmony that are going to bring together the women and the researchers who need them, and then we'll get out of the way.
My daddy said, wait a little birdie till your wings get stronger. But then I got restless.
This is the beginning of the Love Avon Army of Women, but stay tuned because there's going to be a lot more coming from this operation. Thank you. We're going to give you sort of an overview of breast cancer and how we're thinking about it these days and how things have changed, and then be available to answer questions. So put your questions up now, and we got some from Facebook, we've gotten some from the websites, and we'll try to get to all the questions, as many as we can, and those that we can't, we'll give you answers on either online or on email. The big message that I want to get across about breast cancer is really the fact that we've changed the way we think about it. And I think that this message has not gotten out enough. We used to think that breast cancer started in the breast and it slowly got bigger from 1 cell to 2 cells to 3 cells, and then eventually it finally got out of the breast into the rest of the body. And so the goal was to kill every cancer cell. And when you think about it, all the words we use about cancer are war words. I'm gonna blast it away. She won her battle with cancer or lost their battle with cancer. Or they're fighting breast cancer. They're a warrior. They're a survivor. They're all about this war and this battle that's going on. And our other concept is that all cancers were the same. That they all were the same. There was this foreign invader who came in, attacked, and blasted everything away. Well, and in fact, back in 1991, 1992, when they actually looked at what were the characteristics of a cancer, and this is from a famous paper at that time, all of the things they looked at were, again, having to do with the cell itself. So we were really treating cancer like a foreign invader that came from somewhere else and attacked and blasted you away, sort of Osama bin Laden. But actually, it's Timothy McVeigh. It's our own terrorists that we grew ourselves and that in our own environment then got out and caused problems. And so by thinking about it as something from elsewhere, I think we missed the boat somewhat in how best to think and treat it. When you look at breast cancer, it all starts in the lining of the milk ducts, and it slowly fills up in the ducts, and then this is normal. This is the beginning of having these extra cells in the duct. This is when you have even more extra cells, and now you've got precancer in the ducts and little calcifications, and then it gets out of the duct into invasion. So we studied the cells and we studied what changes there were, but we weren't able to really find the magic answers to what makes it invasive and what doesn't.
And I guess the thing was, we really didn't have the tools in the last century to be able to look at it and understand it at a molecular level. That we had some tools to look under the microscope and look at the cells and how they might look different. But you've often talked about the advances that we've made in infectious diseases. It came from understanding that a pneumococcus is different than a streptococcus.
That's right.
And needed to be treated differently. And with the tools we had in the last century, we could not tell really what was going on underneath, both in terms of the cancer cell as well as in terms of the cells around the cancer and the stroma.
Exactly. No, exactly right. And so if you compare to then 1991 to what we were doing clinically, when you look at it, we wanted to find all cancers early because we thought they were all the same and they were going to grow at the same rate. So if we just got there soon enough, we could prevent it. And that was breast self-exam and mammography. And indeed, they sort of work, but they don't work perfectly because the cancers don't all grow at the same rate. Our treatment goal was to, as we said, kill all the cells, and we did mastectomies. We thought it was an emergency, that cancer was going to get out any minute, when actually, it was half the time it was already out. We had one-size-fits-all treatment, and everybody got surgery, chemo, radiation, and all cancers were really thought to be about the same. So if you had a bigger cancer, you got worse treatment, and a smaller cancer, you got better treatment. And that was really the only thing we had. And the final was what we called high-dose chemo and stem cell rescue. We found that the chemo wasn't doing that great, so we thought maybe if we just make more of it and we give even more, and we took people's bone marrows out and we blasted the hell out of them with chemo, and then we gave them their bone marrows back, And so they had the highest dose of chemo they could have, and it still didn't change the outcomes from regular chemo. So that was really the tip-off that we were on the wrong wave.
And didn't actually, in many ways, the surgeons begin to see that we needed to think differently in thinking about the concept of a lumpectomy? Because it was with that older paradigm that you needed to get everything
to prevent it, yeah.
That led you to do a radical mastectomy in everyone, and then it became clear that that wasn't necessarily going to give you better outcomes.
Well, it became clear that some cancers had cells that had already gotten out even when we rushed, and that we were slamming the barn door and the horse was down in the field somewhere, that we needed to do some kind of systemic treatment in addition to the surgery that really allowed us to do less surgery. Now, the problem, though, also with that, besides the fact that it didn't work all that well, was we were overdiagnosing and treating everything the same, that there was a lot of collateral damage from that treatment. Lymphedema from the surgery, complications from reconstruction, radiation-induced cancers, chemotherapy-induced leukemias, chemotherapy-induced heart disease, tamoxifen-induced endometrial uterine cancer, aromatase-induced osteoporosis. So it's not like these treatments are without side effects. And there's a lot of collateral damage. So it really started people thinking maybe one size fits all was not the way to think about this, and maybe we needed to go back to the drawing board. And what we realized, and what we're realizing now in the biology today, is that you need mutated cells, and the mutations can be different in different kinds of cancers. So they're not all the same. There's at least 5 or 6 different kinds, and that they need to be in an environment that's egging them on. So you could have the mutated cells, but if they're not in the wrong environment, they'll do fine. And they'll just stay dormant. But if you have the two together, then you're in trouble. And you get cells from elsewhere. The cancer calls on the bone marrow to send some cells to help along. It's a whole conversation or community or interactive process going on between the cancer and the cells around it that lead to pre-invasive cancer, invasive cancer, and then letting it get out. It's not just a matter of one cell. You need the whole community. It's sort of like if you have a kid that's growing up in a bad neighborhood, and you take him out and you move him to a new place and send him to Boy Scouts and to camp and have different friends, then he'll behave differently. So some of it is the cell and some of it is the neighborhood.
And we've known for a long time that it's not just about the mutations, although clearly the DNA alterations that arise, and these, by the way, are alterations that arise that you're generally not born with. So I think we want to distinguish what we're talking about from heredity, which is the inheritance of an alteration. These are alterations that occur in the ducts, perhaps from younger ages.
Yeah, or not. I mean, it's sort of like, and the older you are, the more chance you have of having them. It's like having dings in your car. Right. The longer you own it, the more little things are going to go wrong, and that happens, unfortunately, with our bodies.
But it turns out that cancer cells don't have the ability necessarily to be able to grow everywhere, and there are many places in the body where, in fact, they don't grow, and we rarely see them.
That's
so,
right.
So indeed, this means that interaction has to be critical for actually us to be faced with clinical problems.
Exactly. So here in this slide, you can see the primary tumor, but then you see there's all this what they call microenvironment, which is really the neighborhood. And that's what decides whether the tumor gets out, and then it also decides whether the tumor spreads into the rest of the body. Now what we think about when we're thinking about how we're going to treat cancer is how are we going to find the tumors that matter, not just any old tumor, because then you end up over-treating it with all those side effects, but the ones that matter, and then how are we going to match the treatment to the tumor, so that much more like antibiotics, again, you don't base what antibiotic you're giving by whether it's a pneumonia or a urinary tract infection. You base it on what bacteria is causing it, and then you give an antibiotic that's going to treat that bacteria. And so our goals then become destroy the cells, but also change the neighborhood. And that's a two-pronged way to do it. And now we know that less may be more, that maybe we don't need to over-treat everybody. So now we do mammography screening, sometimes we do MRI screening. I notice there's a lot of questions about this, and we'll talk about that after. Genetic testing for people who have a strong family history of breast cancer. Drugs for chemo prevention, tamoxifen and raloxifene, which reduce the hormones. We know that hormones change the neighborhood and make it worse, and so reducing them will change the neighborhood. Core biopsies instead of cutting things out. Staging to see which treatment might be best. Oncotype DX is one, mammoprint's another. Ways that you can actually look at the tumor and say, this tumor is going to do better with hormones, this tumor is going to do better with chemo, rather than giving everything to everybody. Sentinel node biopsy, we only take out a few nodes instead of all of them. Intraoperative radiation, sometimes we don't have to do radiation for 6 weeks, we do it for a few days. And then targeted therapies that match the tumor.
And wow, there's a lot now that we know about breast cancer, and a lot that a woman who's newly diagnosed needs to learn about. And so I think this slide also now highlights
all the decision making you have to make.
That there's a lot of decision making, but importantly, it's taking the time at the time of the diagnosis to get the right diagnosis.
Right.
You do have the time to have tests done, to have the tissue looked at in a very careful way.
And to figure out what kind you have.
And to figure out, again, what the right treatment is. And I think the other thing now, and certainly targeted therapies, became a reality in many ways with the poster child of Herceptin for HER2 positive breast cancer, that again it highlighted that we needed to think about that kind of breast cancer differently and treat it very differently with a drug that is a biologic therapy that has side effects but fewer side effects than chemotherapy, and clearly improves survival as we think about the treatment of early disease.
But you could even argue that tamoxifen was the first targeted therapy, actually, because that was saying if the tumor is hormone positive, then we can use hormones. So now we have gotten another level down with that, with tests like the Oncotype DX, where you can say, even though you're hormone positive, you might need chemo, or you don't need chemo because you're hormone positive. So we're sort of parsing it out even further.
Right.
So where we need to go is we need to understand the neighborhood, and we got to clean it up. Clean up the graffiti, get rid of the gangs, put more police on the streets, prevent metastases. And how can we do that? And actually, that's where things like that are often called alternative medicine may have their biggest effect. We know that hormones in postmenopausal women actually aggravate the neighborhood, and if you stop taking postmenopausal hormones, your risk will go down. We know that exercise, if you exercise, you can reduce the chances of getting breast cancer as well as a recurrence. Weight reduction is important, and stress reduction. All of those things, they're not perfect. They're not going to kill the cells, but they certainly are going to change the neighborhood. And in a lot of people, that make a big difference. And then we need to rehabilitate the cancer cells. We need to either put them to sleep or reverse them or figure out or kill them. But in some way, change where things are going. So now it's much more complicated, and this is a map of the neighborhood. But the nice thing about it is it means that we really have a lot of choices, that there are a lot of different ways that we can intervene and try to block things and try to make a difference. So things are going to get even more complicated rather than less.
It does mean that in the last 10 to 15 years, for the first time, again, we have diagnostic tests and tools that can help us look at the pieces and the parts.
Yeah.
And if a car is broken, then you need a mechanic who knows how it's built and knows, again, how it works. Mm-hmm. And therefore, again, we've made a big investment in cancer research as a result, in many ways, of many advocates who articulated for the importance of breast cancer research. Our knowledge in terms of the basic understanding has led us to be able to look at these pieces and parts. And so there are many groups like ours now that are now capable of going out and looking at how can we translate this new genomic information into clinical practice so that it really matters.
Yeah. And this next slide just shows you how you can look at the decision tree. You know, when you have something abnormal, you get a core biopsy as step one, and most of those are actually benign. 90% of them are going to be benign, 10% will be cancer. And then within that, you get two kinds of cancer. One is invasive, and that doesn't mean spread all over the body. It means got out of the duct where it started. And the other is non-invasive, where it's stuck in the duct. Remember that picture I showed a little earlier where you saw the cells crowding the duct? Those are the first steps, and that's about 20%. And then those of the invasive cancers, some of them probably would go, even invasive ones would go away by themselves, maybe 25%. If you look at the studies of mammographic tumors. However, we don't know which ones they are, so we have to treat all of them. Then you've got clinical disease, and then you've got the ones that'll progress if you don't treat them, that'll actually go on to kill you. So somewhere we need to figure out how best to treat things and how in that. So the questions are, which non-invasive cancers found on a mammogram are going to go on? Which ones are going to go on to invasive disease, and which ones are going to just go on locally? And this is a question that we still don't have a good answer to. We need very much a test that's going to be able to look at a non-invasive cancer and say, you know what, this one's never going to do anything. We can just watch you. And this one we got to worry about, and we need to treat aggressively. We have then which invasive cancers are going to go on. Which ones, you know, by how the tumor looks, which ones by how the neighborhood looks, and what can we do to change that. If you look at the breast cancers, the vast majority actually that are diagnosed today are ones that are not going to kill you, the blue. And then there's ones that need treatment, need surgery and chemotherapy, and then there's the non-invasive ones, and then there's a very small number that are diagnosed when they have already spread. So the questions, if you're newly diagnosed, that are important to know is, and if you know, I know a lot of you don't either have already had breast cancer or don't have breast cancer, but these are the questions, if you have a friend or you have anyone, that are important to know. What's the best way to prevent the tumor from coming back in the breast? And that's what surgery does. Surgery can't do anything about the rest of the body, but it can keep the tumor from coming back in your breast. So that's either lumpectomy and radiation or mastectomy. And they're actually equal. They're about the same. One isn't better, one isn't worse. They have the same recurrence rate, and they have the same chance of spreading. So this notion that we have in America that more is always better, and if you do a mastectomy, you'll never get it coming back in your breast again, is unfortunately not true. There's about a 5 to 10% risk of having it come back in the scar after a mastectomy, and a 5 to 10% risk of having it come back in the breast after lumpectomy and radiation. So what really decides what's better is the person's own feelings about it, and the size of the tumor and the size of the breast. Very big tumor, small breast, you might not be able to do a lumpectomy cosmetically, and you might need a mastectomy, whereas at that same size tumor in a large breast, you might be able to get away with. Then the second question is, what's the chance that there might be microscopic cells elsewhere in the body? Because what you die of in breast cancer is not what's in your breast. You could have a lump as big as a basketball, and it would be hard to buy clothes, but that would not kill you. What kills you is when the breast cancer cells are in other more important organs. And so we don't have a way to know for sure that they're there, but we have to look at circumstantial evidence to guess whether they're there. So that goes from the size of the tumor and the nodes, but more importantly, how it looks under the microscope and its biology. And the biology are things like, is it sensitive to hormones? Is it sensitive to progesterone? And does it overexpress HER2/neu, which is a growth factor that tells cells grow harder, stronger, more. So this is the first wave of sort of trying to sort out what kinds of cancer that you have. And you can see here, you go from core biopsy now to invasive, then is it hormone positive or negative? Is it HER2/neu positive or negative? And those tests are done on the slide itself. But then you can go an additional step in terms of matching the treatments. And so then you want to know, which is the best treatment? What if you're, I'm going to go back here, hormone positive and HER2/neu negative? Do you need chemo or don't you need chemo? And that's where additional tests like the Oncotype DX or the mammoprint might be able to help. And then same thing with the ER negative. You want to, if you have ER negative and you have HER2 negative, that's called triple negative, which sounds really horrible. But what it really means only is that the estrogen's negative, the progesterone's negative, and the HER2 is negative. But it does really well with chemo. So it's not as horrible as it sounds.
The reason for estrogen receptor positive tumors that it's so important to get further information is because good surgery, good radiation therapy, good hormonal therapy actually provides excellent outcomes in terms of freedom from having a distant recurrence in, 85% of women. And in fact, the addition of chemotherapy in that case only benefits 4 out of 100 women.
So if you could figure out which ones they are.
And so the goal, hopefully, would be, could we figure out which of those tumors are more likely to recur? Right. In other words, which ones have an underlying biology that would allow them to grow if they were in the bone?
Yeah.
And then the second is, which of them have that underlying biology of either benefiting or not benefiting from chemotherapy? Right. And that's what the clinical research that was done with Oncotype DX demonstrated, is that not all breast cancers that are ER positive are the same.
Exactly.
And that there exists, again, a type that has low recurrence score disease, which is fairly indolent and benefits greatly from hormonal therapy, with minimal
benefit from
chemo benefit, or again with high recurrence score disease where in fact there's such a clear benefit that it's important for women to know that that's an option for them.
Yeah.
And so I guess a question, can you know just by looking at tumor size or tumor grade which tumors have that low recurrence score that can be treated with hormonal therapy alone, and which ones have high recurrence score that should be treated with chemotherapy?
And the answer is you really can't. Yeah. I mean, sometimes the small tumors are the more aggressive ones that are going to spread even faster.
We might have caught them early.
And the big ones are just slow and indolent, are actually sort of lazy and don't get out at all. So it sometimes is counterintuitive, like the lobular cancers tend to be very slow growing and do better with just hormones. And so and don't need the chemo, and you'd hate to get chemo if you didn't need it. So these treatments then are given to match the kind of tumor you have. This just shows you how they figure out some of these different kinds of tumors based on looking at the molecular biology, and some of them will do really well. This top blue line, most everybody does fine, and some of them don't do very well at all, and these ones come down, a lot of people die of these ones, and then these are in the middle. And if you can parse these out and then match the treatment to the kind of tumor, then you're going to get the best outcome with the least side effects that you don't need. So if you look at sort of on a very simplistic way, if you have molecular type where you're estrogen positive, progesterone positive, HER2 negative, with a low recurrence score, then hormones are good. You don't need the chemo and the Herceptin. Mm-hmm. If you're ER positive and or PR positive with HER2 negative and a high recurrence score, then hormones, then you need chemo and chemo and not hormones and not Herceptin. If you're ER positive, PR positive, and HER2 positive, then you get the full, that's like triple positive. You get everything. ER negative, PR negative, HER2 positive, you get chemo and Herceptin, but no reason to take hormones because it's not sensitive to hormones. And then triple negative, chemo. No reason to take Herceptin because it doesn't have too much Herceptin. So it shows you how it gets more and more complicated. It's interesting, the first edition of my book was very small because we only had 1 or 2 treatments, and now it's really fat. So the new way is mutated cell in a supportive environment, find the ones that matter, treat them by changing the environment and knocking them off by the right treatment for the right kind of tumor. as opposed to the old, let's find them, let's blast them away, and the bigger, the more aggressive we're going to be. And these changes have really not, I think, permeated as much through the whole population. So people are still focused on how can we find them early enough, and how can we do the most aggressive treatment possible, as opposed to using this new biological information to match the treatment. Now, most of you know about the Love Avon Army of Women, but I want to remind you, this is a way you can sign up online. There's the website, and we will let you know about studies that are being done to help figure this out. And if you fit the study and you want to do it, you RSVP. If not, you don't. Sort of like eHarmony, you don't have to date everybody. We're happy to have you not only join, but get everybody you know to join. Because if we're going to really get rid of breast cancer, find the cause and stop it, prevent it altogether, it's only going to be if all women are willing to step up to the plate and be involved in really getting us there. So with that, I think we're going to move on to answering some of your questions. We have some questions that came ahead of time, and we can start with those, and then you're welcome to answer your questions online, and we can see them here on the screen and ask them for you.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
It was recommended that I have chemo.
My doctor thought I needed chemo.
Traditional assessment methods said I didn't need chemo.
Many women receive this intense treatment, but only a few will benefit.
But I needed to know.
I needed to be sure. That's when my best friend told me about a test.
My husband told me there was a test.
My doctor told me about Oncotype DX, a test that would help me assess if I would benefit from chemotherapy. This test is not right for every woman with breast cancer.
A woman's doctor can assess what's right for her.
This is about education.
This is about empowerment.
So pass it on.
Pass it on.
Because every woman needs to know.